Thank you for the invitation to speak today. I'm very happy to be here. And I would like to start first of all by just acknowledging some of the contributors to the images in my presentation. So I've referenced them during the slides, but this is, I guess, a collaborative effort. So just by way of overview, I'm going to speak about the amazing anatomy and embryology of limb development, and I'm going to present some pictures relating to imaging the limbs in fetal life. I'll give you a brief introduction to genetics and genetic testing, and then I'll give you 3 examples of genetic conditions affecting limb development. So this morning I was thinking about the presentation and I realised I hadn't put in a slide about how common genetic conditions are in people with limb differences. And so there's a recent, relatively recent study from the States that looked at a 10-year history of a particular hospital, and they found that about a third of children with congenital limb differences were due to genetic conditions. About a third were due to vascular disruption, so problems with the blood supply to the limb during pregnancy. About a third were unknown, and about a few percent were due to what's called teratogen or medication exposure. So, and in terms of the frequency of limb deficiency or limb differences in the community, again, it's hard to get a good figure because it depends what you include in the statistics. So if you're very inclusive and include the major differences through to the less major differences, including fingers and toes, the figure might be something like 1 in 100. But if you exclude what might be seen as more minor differences, then we have a figure somewhere like 1 in 15,000. So it depends on how it's counted. Okay, so just by quick revision, I'm sure this is probably known to lots of people in the audience, but the upper limb is made up of the humerus, which is the upper bone. The forearm has 2 bones, which is the radius and ulna, so the radius being on the thumb side, and then the smaller bones in the hands. And the lower limb is similar, so the femur is the thigh bone, and then there are 2 bones in the lower limb, the tibia and fibula, and then the small bones having a similar arrangement to those in the hands. Okay, so limb development occurs at a very early stage in pregnancy, so much earlier than most people think. So around 4 weeks gestation, we start to see a limb bud. And you can see the top picture there. The arm bud is up the top here, and the leg bud down here. The arm development precedes the leg development by a few days. So, and mostly the limb is completely formed. The limbs are completely formed by 8 weeks, and any further growth is just an increase in size. So many women don't know they're pregnant before 8 weeks. So all of this has gone on, often before there's an awareness of the pregnancy. And the embryological development of the limb is very, very complex, and it's an incredibly delicate process that can be disrupted in lots of different ways. The different tissues need to differentiate into bone, muscle, cartilage, skin, nerves and vessels. And it's not just the different tissue types, but it's also the position and rotation of the limb. And all of those factors have genetic underpinnings, and it's a very complex cycle of molecules that have to interact at the right time in the process for things to progress as usual. This picture just shows you the different colours represent the different nerve roots that come out from the spine in the upper limb here and the lower limb down here. So at 4 weeks you've got this limb bud arrangement. You get elongation of certain nerve roots, but not the upper and lower to the same extent. And then you can see this green line has to rotate all the way around to the thumb side, and the similar arrangement for the lower limb. So you get growth as well as rotation so that everything is in the correct position. And so there are messages for each of those aspects. And it's quite amazing that all of this has happened really before 8 weeks, by 8 to 10 weeks. This just shows it in a slightly different way. You can see the limb bud actually starts really as a sort of solid lump. you get the formation of bone and cartilage from sort of upstream to downstream. And the hands and feet actually start with fusion of the tissue between the digits. And part of the growth is that this tissue in between the digits actually regresses. And that's a sort of a later stage in limb development. So lots and lots of ways in which this process can be disrupted, and the timing is critical in terms of what parts of the limb might be affected. So this is some pictures from the University of New South Wales. They show you in the top row the upper limb and the lower limb, and this is what I was talking about. So you can see the digits or the toes developing here, and there's actually webbing in between, and this is progressing through pregnancy. So you can see the webbing gradually diminishes, and then eventually you have these beautiful toes here, and not quite as clear in the upper limb, but a similar process occurring. So when we think about imaging the limbs in fetal life, typically we talk about ultrasound, and most women would have an ultrasound, or certainly it would be offered at 12 weeks in pregnancy, and by that stage you should get a good view of the limbs. As I said, limb buds really should have progressed by 8 weeks. You can actually see movement by 9 weeks, and the upper bones develop before the lower bones, and then fingers and toes really by 11 weeks. And interestingly, the limb development and the heart development occur at a similar time in pregnancy. So the heart starts off as a tube. It has to grow and fold and develop into a 4-chamber structure. And there are a number of conditions that affect both the limbs and the heart. And that's probably because the messages are important, the genetic messages are important for both those structures, and they're expressed at that time in pregnancy. So this is some 3D ultrasound images from a publication from a few years ago, and it just shows, you can see the embryo here looking quite top heavy. This is the head, and this is the umbilical cord. You can see the upper limbs here and the lower limb here. And this is quite a beautiful picture of the hand. And this is a baby in profile. So you can see the chin, this is the nose, this is the forehead, the back of the neck around here, and this is a little hand poking up here. So quite amazing, and there have been really great advances in imaging technology in the last few years. And this is what you might see on a routine 12-week scan. So you can see this dashed line is a measuring device, so it's like a ruler, and they're measuring the length of the bones. This is the thigh bone here, this is the upper limb, you can see the hand here and the forearm bones. You can see that there are 2 bones there, and this is a foot here. So depending on the position of the baby and the position of and some maternal factors, you should be able to get good images, not always. All right, so as I said, the embryology of the limb is influenced by genetics, and I'll give you some examples of some specific genetic syndromes, but also gene expression. So it's not just what's in the genes, it's what is happening to their expression. Are they switched on or off, and what stage in development does that occur? There are environmental factors that influence limb development. I'm not really going to focus on those today, but in particular things like amniotic bands, drug exposure, and other medical conditions. It's important that the limbs move during fetal development, or that can interfere with limb growth. So it's actually a dynamic system. If a baby has a significant brain abnormality or a neurological problem, and the limbs don't move as they would normally, then that can cause problems with limb development. Okay, and as I said, timing is critical. And this picture just shows you what's referred to as syndactyly. So that's fusion of the skin between the digits, or failure of separation, really. And that's something that happens in that sort of 10 to 12 weeks gestation. So we've all heard about the genetic code, okay? And so we have 3 billion base pairs in our genetic code, and they are labelled A, T, G and C, and they match up like this. And there are about 25,000 genes on the human genome. We don't know what most of them do yet, but new genes are being discovered every week, so it's a very exciting time to be working in genetics. So for most of the genes, we have 2 copies, and the exception to that is those on the X chromosome. So males are X and Y for their last pair, and females have 2 copies of the X. Okay, but we don't know what most of the genes do yet. So the DNA encodes the genes. You can see the code here. That is wrapped into this beautiful double helix, and then that is all packaged up, tightly wrapped around proteins into chromosomes. And so the chromosomes are how the genes are transmitted. This is what chromosomes look like down a microscope. So this is a somewhat old-fashioned way of looking at chromosomes, but it's still a very useful test. You can see that the chromosomes are numbered based on size, and then the last pair for this person is 2 copies of the X, so this is a female. And so one of these pairs comes from mum and one of these pairs comes from dad, and that's why we resemble our family. Okay, but it's not just the genetic code. So the code is in the DNA. That is the blueprint, but that DNA has to be copied. That DNA also has to be transcribed, so that means the DNA is converted into RNA, which is like a messenger. And that RNA then is translated into protein, and protein is the thing that has the function. And the protein has to be formed correctly, it has to be folded correctly. So at each of these steps along the way, there's a number of factors that can occur to disrupt the process. So it's not just about code. So there are different genetic mechanisms that can cause genetic conditions. So the sort of one we've known about for a long time is what's called a trisomy, or an alteration in the number of chromosomes. So this patient has trisomy 18, which means that there are 3 copies of chromosome 18 instead of the usual 2. And patients or children with trisomy 18 can have a quite typical finding of clasping or overlapping of the fingers, and that can sometimes be picked up on ultrasound in pregnancy. You can also have a genetic condition if you're missing part of a chromosome. So that's called a deletion or a duplication. And we've got a lot better at picking these up in the last few years with a new chromosome test that I'll talk about a bit later. This is an illustration that shows part of chromosome 1 is missing. It's the tip of chromosome 1 in 1 copy. So there's 1 copy that it has the usual amount and 1 copy that is missing a part. And these are some critical genes in that region. And 1p36 deletion is associated occasionally with limb differences, but the most significant factor in this condition is learning disability. And we can also get a single change in the genetic code that causes a condition. So this shows you that the C at this letter is turned into a T, and that creates a stop codon, or an ending of the protein. So that is another mechanism which can't be picked up with a chromosome test. You need to do a specific gene test. So I'm going to talk through some different types of genetic testing now. Some of which I've talked on already. So the G-banded karyotype, that's the name for the stripy chromosomes that we saw a few slides back. That's very good at picking up whole chromosome changes like the trisomy 18. It's good for large deletions or duplications. So we measure them in megabase, and it has to be greater than 5 megabase to be picked up with the G-banded karyotype. It doesn't detect the smaller ones or the single gene conditions. It does detect translocations, which sometimes are relevant, and a translocation just means part of one chromosome is swapped over with another. And if that's balanced, meaning there's no loss or gain of genetic material, that usually doesn't cause problems. But when that person has a child, they can be at risk of having an unbalanced arrangement. Okay, so the molecular karyotype is a new test. We've been using it for about 5 years, and it's probably 10 times stronger at picking up deletions or duplications on the chromosomes. So this is a really powerful test. And basically, we label these things called SNPs or SNPs, and we get a readout for each SNP, whether it's the usual amount, so 2 copies, or whether it's increased or whether it's decreased. And so it's quite a complicated process. It uses this amazing little chip, and you get a readout that looks like that. Now, I can make sense of the stripy chromosomes. I can understand losses or gains. I can't make sense of that. I think it looks very pretty, but I can't read it. Fortunately, that we have very large computers that read those and tell us where there's a gain or a loss in the chromosomes, or whether there's the usual amount. So as I said, copy number variants are important. Some of them are benign, so we all have differences in our DNA, that's what makes us different, but some of them are associated with conditions. So in the interest of time, I might just go quickly through this, but essentially this chromosome test is good for deletions and duplications. Okay. but it doesn't detect the balanced translocations and it doesn't detect single gene conditions. So this chromosome test is usually done on a blood sample and results usually take about 6 weeks. So single gene testing is where you, based on the patient's symptoms, you're fairly confident you know what gene is responsible. Most of the time you would have had a chromosome test to rule out a chromosome rearrangement, and the gene then, so a blood test is performed and the gene is sequenced from beginning to end. So that means spelling out every letter of the genetic code for that particular gene, and that can take months. So it's getting quicker, but it used to take 6 to 12 months for that type of test. Now we're looking at probably 3 months, and it's complex if there are more than one gene known to associate with a particular condition, because which one do you choose first? Usually we test the one that's known to cause the most number of cases. Obviously it's reliant on accurate symptom data and the existing knowledge of the gene, so someone has to have discovered the gene, and then a lab available to offer testing. It's usually quite expensive, so a couple of $1,000s would not be out of the ordinary for that type of testing. So new genetic technology, this is a really exciting area. So in the last few years we've had a huge advance in terms of both the computing power and the lab power to test many, many genes all at once. And so we now have these things referred to as multi-gene panels, so we can, depending on the condition, test up to 100 genes at once in a single experiment. The problem is you then have, and in fact you can test the whole genome, so all the genes on someone's chromosomes, you can sequence them. The problem is then you need to filter that data and come out with an answer that explains the condition. So we all have errors in our DNA, we all have differences, and so you end up with 4 terabytes of data basically if you do someone's whole genome, and then you have to work out, well, which of those changes is relevant for the patient. The other problem with that, and this has got a lot of coverage in the press lately with whole genome and whole exome sequencing, is you have these incidental findings. So you might do the test because you want to find an answer for someone's limb issue, and you actually find, you're testing all their genes, you might find they have a predisposition to cancer in adulthood. Now, do you want to know that if you've got a 3-month-old baby? Some people do, some people don't. And so we need to, there's a lot of debate going on about what's the most appropriate way to seek consent for this type of testing, who stores the data, who goes back and reviews the data. So it's a very complex process. So I'm going to give you 3 examples now of different genetic conditions that affect limb development, just to illustrate the types of inheritance and some of the variability that we see in genetic conditions. Firstly, and I guess to guide you through how we think about limb differences and how we make an assessment. So we always think about is it one side affected, is it both sides affected, is it upper and lower limbs, or is it just isolated to one limb? Are there other structural problems? So we always think about growth and development, we always think about the heart, the brain and the kidneys, and we always have to think, is it just the limb, or are there generalised bone problems? So does the child have short stature, for example? Do they have differences in the length of all the other limbs? So is it reflecting a skeletal dysplasia? And the most common would be something like achondroplasia. And we always take a family history, not just for limb conditions, but for other associated problems. So congenital heart disease may be the only clue you get to the fact that something is running in the family. So we want to know, and this is what usually families want to know, is it isolated to the limb or is it associated with a syndrome? And that's particularly in pregnancy, what couples usually would want to know. What's the chance that this child is going to have other problems? And so what are the other health implications? That's a really important question, and how can we maximise that child's health and development? And even in the situation where we think it appears to be isolated, usually we would recommend a molecular karyotype to screen for deletions and duplications. Because if we find something with that test, that potentially has repercussions for the couple having further children, and also for the child's future children. So a genetic condition is more likely if both sides of the body are involved. Just as a ballpark, it's not always true. Obviously, if there's a family history of similar, that makes us suspicious. And then if there are other structural malformations, including particularly the heart, as I mentioned. Okay, so I'm just going to talk through the 3 examples now, starting with Holt-Oram syndrome. This was first described in 1960. It's not particularly common, 1 in 100,000 live births, and it is the association between congenital heart disease and upper limb differences. So particularly the classic findings are affecting the thumb and the radial side of the hand, of the limb, and atrial septal defects. So that's a small hole between the 2 atria within the heart. But it is very variable. The heart can be structurally normal, and one of the manifestations can be a conduction problem. So the rhythm of the heart is affected, but not the actual structure of the heart. Often we'll find that a parent has mild symptoms. For example, it could be as mild as a flattening of the muscles over the base of the thumb, or a slightly small appearance to the bones in the thumb on X-ray. And there's no associated intellectual disability with Holt-Oram syndrome. So these pictures just show you some of the variability we can see. This is a patient who is missing the thumb, so the thumb failed to develop. And this is a patient, you can see a curving of the forearm bone, and then some of the digits are missing. So quite a broad range of differences. And I think one of the sort of recurring things in each of the conditions I'm going to talk about is that we can't make a diagnosis just based on the appearance of the limb. We need to think about the whole picture. This is another patient with Holt-Oram syndrome, and you can see the changes here are quite subtle. This is what we refer to as a different insertion of the thumb. So if you look at your own thumb, the thumb typically inserts a little bit upstream of the knuckles, whereas this patient has an insertion that's close to the knuckles, so it's more downstream than usual. And on this side, there's a fusion between those 2, the thumb and the first finger. And this shows you just a scan of the heart, and that there's a little gap between the 2 chambers. Normally you'd expect that to be closed. So quite a variable condition. It's an autosomal dominant condition, but it has variable features. So a dominant condition means that if a parent has the condition, there's a 50% chance for each pregnancy that a child will inherit the condition. But there's no guarantee that the child will have the same features as other people in the family, so they can have a whole range of features. So this just illustrates dominant inheritance. So you can see in blue, this is the gene change that causes the condition, and then the brown here is the gene without the change. And so the father in this example has a copy of the gene that's changed, and so that just shows you he has to give this one or this one to each pregnancy. And so boys and girls are equally affected. And it's important, obviously, to make an assessment of parents to work out whether they might have clinical signs. So the gene for Holt-Oram syndrome was discovered in 1997, but it only explains about 30% of the cases if you look at the large cohorts. And so we still don't know what the other 30% is due to, and it's likely there'll be other genes that are yet to be discovered. And so Holt-Oram syndrome falls under the umbrella of the heart-hand conditions that I was referring to earlier, and you might have heard of some of the others I've listed there. Okay, I'm going to talk next about Cornelia de Lange syndrome, which is also a dominant condition, but it's different to Holt-Oram in that there's no association with intellectual disability in Holt-Oram. However, Cornelia de Lange syndrome is associated with intellectual disability. Again, the features are very variable, as you can see. Short stature and microcephaly, so that means a small head size. Typically the upper limb is more affected than the lower limb. And although it is dominant, like Holt-Oram syndrome, most cases are sporadic, which means that the chance of a sibling having a similar condition is very low. And this just shows you, I guess, the variability that we see within this condition. That the boy here, you can see, has a much more significant issue with his upper limb, whereas in fact the findings in this young girl are very mild, and in fact they have differences in different genes. So he has the NIPBL gene involved, and hers is SMC1A. So we see variability within a condition. And this again shows you the differences you might see in limb development. So this patient obviously has a more significant change than this patient here, and then something sort of in between. So again, you can't make a diagnosis based on the appearance of the limb. You really need to think about the entire child and think about all aspects. So the third condition I want to talk about is called, or referred to as, TAR syndrome. Thrombocytopenia refers to low platelets, and platelets are important for clotting in the blood. So the two classic features are low platelets and a small or absent radius on both sides. So that's the thumb side bone in the forearm. But other bones can be affected, and the thumbs are usually present. It can also involve the lower limbs, and there can be other organs involved, and usually intellect and development is normal. So this just shows you some examples of children with TAR syndrome. The platelets can cause bleeding. This just shows you petechiae, which is bleeding into the skin and bruising, and so that's usually most significant in the neonatal period, so in young babies. And the bleeding can be significant, including into the brain, and then that can cause problems, obviously, with learning disability. This is an X-ray which shows you a single bone in the forearm on both sides and some differences in the hand bones. And this young girl, you can see she has shortening of both upper limbs, and she also has involvement of her lower limbs. And this just, again, to illustrate, although radius is in the name of the condition, the lower limbs can also be affected. And you can see this is an article from a few years ago, but this young boy had quite significant knee problems. So TAR syndrome is an autosomal recessive condition, and we knew that there was a particular chromosome deletion on chromosome 1 that involved a gene known as RBM8A. We've known about that since 2007, but we didn't really know why some people with that deletion had TAR syndrome and other people didn't. It was only in 2012 that people identified that there was a single change in the genetic code on the second copy of that gene that explained the condition. So when we talk about recessive conditions, the recurrence for siblings is 25%, but in TAR syndrome, we know that this represents the deletion, and this represents the spelling mistake in the other copy of the gene. We know that the deletion is only inherited in about half the cases. So when we diagnose someone with TAR syndrome, we would always check for the chromosome deletion, and then we would do a chromosome test for both parents to work out whether the deletion was inherited or whether it was new in the child. Because if it's new in the child, then the risk of having a sibling with a similar condition is much, much lower. Whereas if we confirm that this situation is correct, one parent has the deletion and one parent has the spelling mistake, then we know that there's a 25% chance of it happening again, of that combination. So just to conclude, genetic conditions affecting limb development are rare, but they are very important, and detailed assessment and correct diagnosis is important, firstly for prognosis, so what can we expect for the future of the child or the future of a pregnancy if we're making the diagnosis in pregnancy. Health surveillance, so what are the other complications we need to think about for the child? Do we need to screen the heart? Do we need to screen the kidneys? And learning and development, is that going to be involved or not? Genetic counselling, obviously we need to make the correct diagnosis so we can give accurate genetic counselling to the families. And it's not just for the couple and the child, but it's also for the extended family and for the child's future children. So understanding the basis of their condition is going to potentially be something that's important for them, very important for them in their life and when they're planning their own families. And obviously appropriate family supports is critical, and that's why events like today are so important. So hopefully I haven't bamboozled you with too much information, but I'm very happy to take any questions if I'm allowed. Well, I guess I'm biased. I think that if you have just an isolated limb difference, the chance of picking something up is low. for example, a chromosome test, but it would be a few percent. I don't know the exact figure, and that would be. I think it is important for understanding why it's happened and understanding perhaps what the chance might be of a second child with the condition. So I would recommend that, but other people wouldn't. So it depends on families' wishes and also on different clinicians, I think. But yeah. So usually we would go back and look at the ultrasound in pregnancy, and so usually at about 20 weeks into the pregnancy there will be a screen for structural changes. So they check the brain, the spine, the heart, the kidneys, all of those things. And if that looks normal and there's nothing on examination to suggest, for example, congenital heart disease, then you may not. It depends a little bit on where you are. If you're somewhere remote, then you might not get that sort of detailed level of assessment. If you're in a major centre, then you're more likely to probably get an assessment and potentially things like a renal ultrasound, a kidney ultrasound and a heart ultrasound. So that would be, that would probably be the minimum, I think. And a chromosome test, I think, is important. So for the chromosome testing, that's covered by Medicare. Yep. So that's not an out-of-pocket cost to families. If you, I guess the expense I was referring to was single gene testing, and then the multi-gene panels and the exome sequencing is very expensive. At the moment, as a ballpark, to get an exome, it's about $5,000. That's not covered by Medicare. Now, in future, that is going to get cheaper and the testing is going to get better because that level of testing is just in its infancy. But I think, depending on the particular, it really depends on the particular issues of your child, I guess. So I'm not sure I can answer that specifically. But so some genetic tests are covered by Medicare, but others aren't. And probably discussing with your doctor would be the best thing. Yeah. Doesn't matter, it's not going to change with time. And if some families really are driven to find an answer and want to pursue all sort of diagnostic tests, other families think, well, it's not going to make a difference. It's not like it's not going to make a difference in terms of treatment. So let's just see how things go. And if he or she is asking questions when they're older, then we can pursue it. So it's really individual, I think. I think it's worth recontacting them and saying, is there anything new in this area based on what you know about her? Would you recommend any further testing? Yeah.